of Intellectual Disability. And she's just going to say a few words about Alan because she has worked with him for quite a significant number of years. So over to you, Sharon.
Thanks so much, Catherine, and thank you for asking me to say a couple of words about Alan. I first met Alan in the mid-90s when we were both doing the child and adolescent MPhil at Red Cross Hospital, and already then engaging with him, I was struck by his amazing capacity for understanding processes and issues and people and how to bring all of those things together to, work towards actionable change for mental health. So it was not surprising to me that when I really excitedly saw the call for DFID in 2005, that his face was the first that came to mind. And when I called him, he said, we'd already put in an application. And that was the first 5-year DFID grant that was subsequently followed by many other grants that led to the setting up of the Center for Public Mental Health, the Alan J. Flisher Center for Public Mental Health. And I mentioned this long trajectory of development because I think at the time, for those of us that were involved in the work that came out of the DFID grant, it really made sense for us to ask family permission for us to name the center after Alan, because we really felt that Alan's, as a person, as a researcher, as a service provider, really epitomized for us the qualities that we want to see in the center going forward. And I can mention many, but I'll just mention a few. I mean, Alan's humility and engagement with a wide range of stakeholders throughout Africa and globally is still a core principle that the center holds. His service orientation and his prolific research portfolio, still, I mean, the other day, just before you asked me to say these few words, I was doing a search and there was a publication 2012 of Alan's work that was still informing us, even though he had passed in 2010, his work was still being published. He had a visionary research lens which really aimed at building capacity for improving service development. So, the norms and standards that he developed, the national mental health policy, all of that came ahead of his time. And I think the center still epitomizes that in terms of leading with, what's next, what is needed next. And then capacity development, whether it's in-service mentoring or, students that he produced who are now still making changes. I mean, I was his PhD student. I don't know if I'm making changes, but certainly you are, Catherine, Creek before you, and there are many other examples of people that benefited from having Alan as the supervisor. And he just worked very quietly in the background, getting on with things while others might actually have taken, the frontline credit. And I think that was Alan's genius, that he knew how to engage people in a way that made processes move forward and which resulted in change. And I think he would be very proud to know that the center, which bears his name, so epitomizes those principles. So yes, as we think about Alan and his work, he for me is still very relevant, and his qualities as a person remain with me, and I often think about that when I'm doing my own work, and no doubt as many of us do. I'm looking forward to Soraya's talk, which also leads to the same kind of focus. So thank you for letting me say a few words.
Thank you so much, Sharon. I really appreciate you taking the time today and sharing some of your experiences of working with Alan. So I'm going to introduce you to Soraya Seedat, who is here. She's a professor and a psychiatrist by training and chairs the Department of Psychiatry at Stellenbosch University. And she's been involved in traumatic stress research for over 20 years and holds a South African research chair in PTSD and directs the South African Medical Research Council Genomics of Brain Disorders Research Unit. So we're really happy to have Soraya here with us today. And it's very nice. She's actually in another room at the center, so we're all kind of together, but technically separate. So Soraya, if you're there, we can put your presentation up and welcome.
Good afternoon, everyone. It is truly a privilege to be giving the Alan J. Flisher Memorial Lecture for 2021. I knew Alan as an early career researcher, and our paths crossed quite early in my career, and I grew to truly admire Alan for his work and his collaborative spirit. And in fact, Alan in large part inspired me to undertake research early on in my career in child and adolescent trauma and post-traumatic stress disorder. These are my disclosures. So rather than focus on research that I have been involved with over the last few years on trying to understand the genetic and neural underpinnings of post-traumatic stress disorder and infectious disease and other non-communicable disease comorbidities, I have decided today to focus my talk on a broad-based overview of trauma and post-traumatic stress disorder, and more specifically to examine some of the conceptual issues in the field of trauma and post-traumatic stress disorder, to extend that to our understanding of the COVID-19 pandemic and how trauma and post-traumatic stress disorder has been conceptualized and researched during the pandemic. And then I will end off with speaking about existing treatments for post-traumatic stress disorder and briefly cover some of the newer treatments, some of the more exciting treatments for post-traumatic stress disorder. Memories of traumatic experiences not uncommonly cause deep but invisible scars. And one of the psychopathological consequences of trauma exposure that exemplifies this is PTSD, which is a disorder that focuses on aberrant fear and memory. So trauma is the Greek word for wound, and tales of trauma and the profound consequences of trauma actually date back to writings in antiquity. It was in the late 19th century that Pierre Janet and Sigmund Freud provided first writings on the characterizations and clinical implications of traumatic events and described this as a hysteria and the etiology of hysteria, which was a consequence of experience to psychological trauma, especially sexual trauma. Now, contemporary definitions of trauma have become largely fashioned from war trauma. And this was mostly described during World War I and II and the Vietnam War. So although traumatic stress has been around for more than 100 years and has been known by a variety of terms, including shell shock, battle fatigue, soldier's heart, it's only been in the late 1980s that the persistent reactions that are associated with trauma have been recognized in the psychiatric nomenclature. And this really came to the fore during the Vietnam War, as these psychological responses were seen in many troops returning from their deployment in Vietnam. And so the Diagnostic and Statistical Manual, and the third edition, specifically at the time, introduced the diagnosis of PTSD. So a traumatic event is the foundation of the diagnosis of PTSD, but that traumatic event respects the intensely heterogeneous nature and symptomatic presentation of the disorder. So while it is a fairly relative newcomer in the psychiatric nomenclature compared with a serious mental illness like schizophrenia and bipolar disorder, a fundamental feature of PTSD is that it's remained constant over time. And that constancy relates to the conditional definition of PTSD, which is based on linking symptoms to a qualifying trauma exposure. And this feature is at the heart of the complexity of the diagnosis of PTSD. So understanding this condition requires the conceptual differentiation of trauma, the exposure to that trauma, and the psychological response to it. And this is why I thought it would be particularly important today to discuss some of the conceptual definitions of trauma and to reflect on how this field has evolved. So the effects of trauma are pervasive and can be harmful for many individuals who are exposed. What is a very common presentation of trauma is a subclinical symptoms and a heterogeneous array of symptoms. But a small proportion of individuals who are trauma exposed will develop psychiatric disorder, and PTSD is just one of those manifestations. It is the quintessential trauma-related disorder, but a number of other psychiatric disorders can emerge as a consequence of trauma. And I think that is important to bear in mind. So when disorder emerges in the consequence of trauma, it is typically associated, in the case of PTSD, with impacts on quality of life, as well as impairment in functional recovery. So several decades of PTSD research has led to a number of important conclusions about the nature of potentially traumatic events. And on the right of the screen, you will see a depiction of the prevalence of trauma exposure in relation to the prevalence of both developing PTSD or not developing PTSD. So although the majority of people exposed to at least one traumatic event in their lifetime may experience early post-traumatic stress symptoms, so very transient symptoms of stress and distress, only a small subset go on to develop PTSD. And this has been exemplified in many multinational studies that have been conducted, including the World Mental Health Survey's initiative, which was conducted in over 20 countries, assessed a variety of exposure to lifetime traumas, and found that more than 2/3, so about 70%, of participants had experienced lifetime traumas. And on average, an individual experienced about 3 traumas across the lifespan. So when we look at the prevalence rates of post-traumatic stress disorder in various countries around the world, you can see that there are differences, and there are differences in terms of the income status of the country, so where the country is classified as a high-income country or low and middle-income country. I want to take you again to the graph on the right-hand side, which reflects a variety of traumas, including interpersonal and non-interpersonal traumas, and points out that rape is the most pathogenic trauma for post-traumatic stress disorder. This has been consistently demonstrated. But in addition, childhood exposure to trauma, neglect, also carry a very high conditional risk for post-traumatic stress disorder, as well as other mental health outcomes. Now, while the variation in rates of trauma exposure, as well as the prevalence of PTSD, varies around the world, I think one needs to bear in mind that the differences in prevalence may, to some extent, reflect true differences, but they also reflect other methodological artifacts, including differences in terms of reporting by region, cultural willingness to disclose trauma exposure, as well as the way in which a trauma is labeled as either violent or unwanted. So we'll look more specifically at trauma and post-traumatic stress disorder in our part of the world. I think that there is now a good body of evidence that shows that people who live in sub-Saharan Africa are disproportionately affected both by individual level as well as population level traumas over the lifespan. In fact, on the African continent, rape and partner violence as well as other forms of assaultive violence in South Africa. Now, looking more specifically at post-traumatic stress disorder, the pooled prevalence of probable post-traumatic stress disorder in individuals who are exposed in sub-Saharan Africa is around 22%, so roughly 1 in 5 adult and youth will meet criteria for post-traumatic stress disorder. Despite this, we know that only a small proportion of those individuals receive any type of treatment. And if you look across the world, I think that the situation with post-traumatic stress disorder mirrors what is seen with a wide variety of other psychopathology. In fact, most mental disorders, in that there is a very wide treatment gap by income status of a country. So I did say that second to a rape, which is the traumatic type that carries the highest conditional risk for post-traumatic stress disorder, early childhood trauma is also associated with a high conditional risk for post-traumatic stress disorder, but a variety of other mental health as well as physical health outcomes. This has been a focus of research in the last 10 years, especially with regards to trying to understand the mechanistic underpinnings of childhood trauma and later life mental health outcomes. So the definition of trauma in our diagnostic nomenclature, both the DSM and the ICD, has evolved over time. These are the two diagnostic nomenclatures that we currently use around the world. And as you will see, when trauma and post-traumatic stress disorder was first included in the DSM in 1980, trauma was defined as a recognizable stressor that would evoke significant symptoms of distress in almost anyone. But that definition changed with the DSM-3R only 7 years later, where trauma was then defined as being an event that was outside of the range of usual human experience and that would be markedly distressing to almost anyone. And it was at this point in time that there was an additional requirement that that event had to involve serious threat to life or physical integrity. So many years down the line, we now have the DSM-5 and the ICD-11. And you will see that the ICD-11 has broadened the definition of trauma to include repeated or extreme exposure to aversive details of trauma, but only if it is work-related, while the ICD-11 has a much narrower definition of trauma, which defines trauma as exposure to a threatening or horrific event or series of events. Now, in relation to the presentation of traumatic stress symptoms following a traumatic event, the DSM-5 has expanded on the symptom criteria, and that has been met with a lot of controversy. So until the DSM-4, we had 3 different types of symptom clusters that needed to be present in order to make the diagnosis, but DSM-5 has extended this to include a 4th cluster relating to alterations in cognition and mood. And the question is whether we now, with the DSM-5, as well as the ICD-11, have a nondescript classification. I think when you change your slide, so we're getting lots of feedback from the speaker here. Apologies, so I hope this will be better. So the question is, do we have a nondescript classification of PTSD, both in the DSM-5 as well as the ICD-11? And it has been said that there are many, many ways to have post-traumatic stress disorder, and this is indeed true, that there are more than 600,000 ways if you look at the different symptom permutations that can be used in making the diagnosis of post-traumatic stress disorder. So conceptually, this presents a problem, and it presents a problem when you are making the diagnosis of post-traumatic stress disorder using this classification, the DSM-5, versus the ICD-11. So this is a comparison of the diagnostic criteria for PTSD by DSM-5 and ICD-11 diagnosis. And you will see that the ICD-11 diagnosis is a much narrower definition of post-traumatic stress disorder, and it is more closely aligned with regards to the symptom presentation with the DSM-4 definition of post-traumatic stress disorder. Now, ICD-11, in contrast to the DSM, has introduced a different type of post-traumatic stress disorder, which is known as complex post-traumatic stress disorder. And this is a sibling condition, if you will, to PTSD, and may in fact be slightly more common than PTSD. And what it requires is the presentation of the core symptoms of PTSD, which I have just discussed. And in addition to that, the experience of disturbances in self-identity, persistent difficulties in interpersonal relationships, and emotional dysregulation. And this is a condition that is most commonly seen in adults following exposure to prolonged childhood abuse and maltreatment, although it can also be diagnosed in the context of other severe traumas. So in making the diagnosis of post-traumatic stress disorder, in addition to the symptom level disturbances, it is important to differentiate between the early effects of trauma and typically what we refer to as acute stress disorder, which is a diagnosis that can be made within the first month of trauma, and post-traumatic stress disorder, which is a diagnosis that can only be made following a month after the trauma exposure. And we know that acute stress disorder is not a very good marker of the later development of post-traumatic stress disorder. And in fact, at least half of all individuals who develop post-traumatic stress disorder don't in fact have an initial diagnosis of acute stress disorder. So this makes it particularly difficult when trying to identify early markers of post-traumatic stress disorder. And this is, in fact, a disappointing evolution of the diagnosis over time, in that ASD, in fact, has limited benefit in predicting who will develop post-traumatic stress disorder and who will not. Now, initially, acute stress disorder was thought to be a variation of post-traumatic stress disorder that was primarily characterized by peri-traumatic dissociation, and so very prominent dissociative response. But the DSM-5 has changed this based on emerging research to show that those specific symptom clusters do not necessarily need to be present to make the diagnosis of acute stress disorder. So acute stress disorder more closely resembles post-traumatic stress disorder. So as I mentioned at the outset, the majority of trauma survivors will have early symptoms of acute stress that will subside over time. And in fact, only 30% of individuals will develop a chronic post-traumatic stress disorder. So recovery in post-traumatic stress disorder is seen as a resolution of symptoms as well as substantial improvement in functioning. And the question is, if 30% of individuals will go on to have chronic post-traumatic stress disorder, what can we say about the 70% who do recover? Do they all recover in the same way? Well, they do not, because there are different forms of recovery in the early aftermath of exposure. And so what can be seen is that you have individuals who may rapidly remit, you may have individuals who more slowly remit, and those who don't remit are those who develop chronic symptoms, who have persistently elevated symptoms. Now, what I have shown here are some data from a study that I was involved with together with colleagues at the MRC unit on gender and health. And it was a study that was led by Professor Naima Abrahams that followed up women who had been raped compared to women who had never been raped over a 3-year period. And the data shown here cover the first 2 years of the study. And these were women who were recruited from rape centers for the rape-exposed women. And the women who had never been raped had been recruited from family planning clinics. These were women who were young adults between 16 to 40 years of age. And on the left-hand side of the screen, you will see the proportion of women with post-traumatic stress symptoms comparing women who were raped with those who were not. And you will see that, the women who had been raped had very high levels of post-traumatic stress in the weeks and months after the rape. And although there was a decline in post-traumatic stress symptoms in the 3 to 6 month period, nearly 1 in 2 women who had been raped continued to have significantly high levels of post-traumatic stress symptoms compared to women who had not been raped, whose symptoms of post-traumatic stress remained low from inclusion of this into the study over the 2-year period. Now, that was also mirrored in terms of suicidality as well as depression. And on the right-hand side, you will see the proportion of women who reported suicidal ideation. And the study found that many women who had been raped contemplated suicide, and about 1 in 8 continued to have thoughts of suicide over the following 2 years. And this was a much larger proportion than among women who had not been raped. So the primary focus of the study, which was the RISE study, was really a study that aimed to track new HIV infections, so HIV incidence in women who had been raped. And what you see here is the incidence of HIV, so new infections of HIV, which were assessed at each follow-up visit. And the purple line shows the incidence among women who were raped, and the pink line, those are the non-rape exposed women. And you will see that the HIV incidence was quite similar between the groups at 3 months. But this changed over time, with the group of women who reported rape having significantly more new HIV infections than women who were not raped. And this was a pattern that was consistently seen over time. So as I alluded to, PTSD doesn't follow a linear course, and there are many different trajectories, and it is important to look at this trajectory, which is the recovery and resilience, or these trajectories, to look at these trajectories, which are the kind of resilient and recovery trajectories in women and men. And it's important to identify these trajectories because they can help us improve early detection of post-traumatic stress disorder. So these are data from a study that we were fortunate to collaborate on. And this was a study that aimed to pool data through a consortium to develop a risk estimate tool to calculate an individual's likelihood of PTSD from early predictors. So this was a study where researchers shared participant level data from 10 longitudinal studies of civilian trauma survivors, and these were trauma survivors who had been admitted to acute care settings in 6 countries. And these were individuals who were assessed very early after trauma and then followed up within 4 to 15 months of having that trauma exposure. All participants were assessed by a clinician. And the intention was to try and develop a risk estimate tool to see if it was possible to calculate an individual's likelihood of PTSD from early predictors. And what the study found was that a cluster of markers was able to predict the likelihood of developing PTSD, and this cluster included very severe symptoms early on, female gender, having less than secondary level education, so low level of education, and exposure to past interpersonal trauma. So together, these markers or these features was able to predict a greater likelihood of developing PTSD. So when we think about early identification of post-traumatic stress disorder with the intention of intervening early, I think it's important to think about the multifactorial etiology of post-traumatic stress disorder. This is a disorder that has to a large extent evaded researchers and clinicians in the field. Just in terms of developing effective treatments to manage that 30% of individuals who have a chronic course. And within that 30%, approximately 40% of those individuals will not respond to first-line treatments. So the etiology is, as you would expect, multifactorial. And as I indicated at the outset, I have been particularly interested in the genetic and epigenetic factors that contribute to PTSD. So PTSD is a condition which may be surprising to know has a very high heritability. In fact, the heritability of post-traumatic stress disorder is between 40 to 50%. And there have been many efforts and much advance in understanding both the genetic and epigenetic contributions of post-traumatic stress disorder. But there are a number of other factors that play an important role. It is also, I think, very telling that women in particular have a much higher risk of post-traumatic stress disorder than men. And in fact, women have at least a twofold higher rate of post-traumatic stress disorder following trauma exposure. Now, essentially, this may be to some extent due to the disproportionate burden of interpersonal violence, particularly sexual assault in women, but it also relates to other social and ecological vulnerability factors, as well as a number of biological vulnerability factors, including hormonal and reproductive factors, sex differences in brain arousal symptoms, and their regulation by stress. And genetic studies have also confirmed a higher heritability in women, with molecular genetic studies showing that there may be variations in certain genes in the hypothalamic pituitary axis in relation to PTSD risk in women. So when we look at the neurobiological underpinnings of post-traumatic stress disorder, post-traumatic stress disorder is by and large conceptualized as being underpinned by cognitive and biological models. And both of these models address attentional bias towards threat. So cognitive models of post-traumatic stress disorder recognize the role of fear conditioning in the etiology of post-traumatic stress disorder, and also place much emphasis on memory and memory disturbances in post-traumatic stress disorder. And so individuals with post-traumatic stress disorder have both emotional undermodulation as well as overmodulation. And emotional undermodulation involves decreased prefrontal inhibition of circuits that are involved in emotion processing, while overmodulation actually represents an exaggerated dampening of emotional expression and detachment. And this relates to many of the avoidance and numbing symptoms that one sees in post-traumatic stress disorder. Now, another multi-organ system that has been implicated in post-traumatic stress disorder is the hypothalamic pituitary adrenal axis. And there is very good evidence that there is marked dysregulation of this axis in individuals with post-traumatic stress disorder. And this dysregulation may, to some extent, explain the high rates of comorbidity of post-traumatic stress disorder with other mental disorders, more specifically other anxiety disorders, major depressive disorder, as well as substance use disorders, but also provides some explanatory model for why post-traumatic stress disorder is highly co-occurrent with a number of medical conditions. And one that I've been particularly interested in is metabolic syndrome, because metabolic syndrome is very prevalent among South Africans. It is associated with the doubling of the risk of cardiovascular disease, as well as more than a threefold increased risk of type 2 diabetes. And because they're both prevalent conditions, and because PTSD independently increases the risk of metabolic syndrome, as well as independently increases the risk of incident cardiovascular disease, I think it is very important to try and understand some of the shared underpinnings of PTSD and its comorbidity. Apologies, my slides just seem to have taken a life of their own. So as I was saying, PTSD is associated with a number of biological perturbations, and it is important to, in trying to understand both the mechanisms, but also when intervening in terms of both pharmacological and psychotherapeutic management, to think about these comorbidities, because comorbidities in post-traumatic stress disorder tend to be the rule rather than the exception. And untreated post-traumatic stress disorder, as well as undiagnosed comorbidities in post-traumatic stress disorder, are associated with an increase in mortality. In fact, premature mortality, increase in kind of biological and cellular senescence, and biological aging. So I'm going to move on to talk about interventions for post-traumatic stress disorder. And I want to point out that this is a field that has been very exciting in recent times because of new interventions that have been examined. I also want to say that for some reason my slides are not behaving themselves, so I should have discussed this right at the end of my presentation. I was going to move on to discuss the conceptualization of trauma and post-traumatic stress disorder during COVID, but maybe I'll get those slides back. So when we think about interventions for post-traumatic stress disorder, the first line treatments could either be psychological interventions or pharmacological therapies. And so I think there is now very good evidence that trauma-focused interventions, especially cognitive behavior therapy, cognitive processing therapy, cognitive therapy, EMDR, have very good evidence for efficacy in post-traumatic stress disorder. Pharmacological therapies can also be used as first line. Not all treatment guidelines would recommend pharmacological therapies as a first option, but some do. And the selective serotonin reuptake inhibitors and the serotonin norepinephrine reuptake inhibitors have been most widely studied and have been found to be effective. When it comes to early interventions, early cognitive behavioral interventions have been shown to significantly reduce the prevalence of post-traumatic stress disorder. I apologize, I'm just not able to. Okay. So my slides have really kind of got all mixed up, but maybe I should just move on to finishing off treatment, and I can get back to discussing COVID. So when we think about early cognitive behavioral interventions, I think we need to think about prevention, and prevention could either be universal prevention, it could be selective, or it could be indicated. So universal prevention really speaks to population level interventions that are delivered before or within the first 3 months of a traumatic event. And as I mentioned, the most robust findings are for CBT, but the evidence is for individuals who already meet the diagnosis of an acute stress disorder. So in fact, work in this area has been somewhat disappointing because there is no good evidence that selective or indicated interventions are in fact helpful. I mean, indicated interventions would be those that are administered to individuals who already have symptoms of post-traumatic stress, but who do not meet the criteria for diagnosis, so may have subthreshold symptoms. Where selective interventions would be those that would be targeted at high-risk groups. For example, first responders. In the context of in the context of COVID, and I think this provides a good example of early interventions and prevention more specifically, there has been a lot of focus on addressing the mental health of frontline workers and other essential workers during the pandemic. You know, the question is there evidence to support this? So these are data that come from a Cochrane review, and you know, this Cochrane review was conducted in 2020, and there have been studies and more evidence that has emerged since then, but not much evidence to inform the kind of wider implementation of preventive interventions. And at this time when this Cochrane review was conducted, you know, the conclusions were that there was a lack of both qualitative as well as quantitative evidence from studies carried out not only during COVID-19, but during the other pandemics of the 21st century that could actually inform the selection of interventions that would be beneficial to the resilience and mental health of frontline workers. So resilience has been the focus of prevention, particularly among frontline workers. And, you know, resilience actually refers to this ability to adapt and bounce back from unpleasant situations. And resilience has, you know, been widely bandied about and often sort of used in, you know, the inappropriate context. And there is a lot of debate about what resilience actually encompasses, you know, in the context of COVID-19. So resilience, you know, is an interrelated concept with post-traumatic growth and with coping. And these are all metrics that have been examined during this pandemic and in previous pandemics as well as in non-pandemic times. And I think that, you know, there is good evidence that resilience moderates the relationship between post-traumatic stress disorder and post-traumatic growth. And so it is encouraging that, you know, many interventions that have been delivered to frontline workers have focused on building resilience, not just individual resilience, but also organizational level resilience. So within our own setting during COVID-19, we set up a frontline resiliency intervention for this purpose. And you know, this was a blended hybrid intervention that incorporated psychological first aid with another intervention that has good evidence for effectiveness and that is rooted in cognitive behavioral and family therapy principles that, you know, would be, I think, appropriate to combine with psychological first aid, because psychological first aid is really a very early intervention. And many other centers, you know, around the world, clinical and academic centers, have used psychological first aid and blended it with some other early trauma-focused intervention for frontline healthcare workers. So just want to get back to therapies and to psychotherapies more specifically. And, you know, the question is, how effective are therapies for post-traumatic stress disorder? And what you see here is a comparison of the effect size, and that is really an indication of the size of the effect of an intervention, in this case psychotherapy, compared to a control intervention for post-traumatic stress disorder, as well as a number of other disorders. And what you can see, if you look specifically at post-traumatic stress disorder, is that the effect size is good. The effect size is over 1.62, and the number needed to treat is 1. And the number needed to treat is an indication of the number of people that one needs to treat to get one other person better. And so in the context of any condition that you are treating, a lower number to treat is always kind of more favorable. It's more beneficial. And, you know, this actually shows you the effect size of post-traumatic stress disorder relative to other anxiety disorders, but also depression, bipolar disorder, and psychotic disorders. And as would be expected, you know, psychotherapeutic interventions for patients with psychotic disorders have much lower effect size. So, you know, that is well and good, but it is also important to bear in mind that only 2/3 of patients respond adequately to psychotherapies. And that is also true of first-line pharmacological interventions for post-traumatic stress disorder, both SSRIs and SNRIs. And so, you know, the question is, what about newer treatments? Can we harness other treatments, maybe repurpose old treatments, or consider treatments that may have an impact on, you know, the behavioral and cognitive models of post-traumatic stress disorder? So in terms of targeting fear extinction. And so there has been, you know, a lot of excitement in this area, and there have been a number of new treatments that are currently under investigation. I mean, one of them is ketamine. Ketamine is an anesthetic analgesic, and it's a compound that offers a very novel mechanism of action. It's been around for a long time. And the mechanism of action of ketamine is as an NMDA antagonist. And what it does do, and this is why it's thought to be a suitable agent for post-traumatic stress disorder, is that it alters memory consolidation and it enhances fear extinction. You know, it may also in tandem improve synaptic plasticity. So there has been some recent work where in a randomized controlled trial in patients with chronic PTSD, ketamine was administered, and it is administered intravenously, which raises questions about the feasibility of this kind of treatment in, you know, routine care. But in any event, the findings of intravenous administration of ketamine, which was given as 6 consecutive infusions over a period of 6 weeks, so weekly infusions, compared to midazolam, which was the comparator agent. You know, the outcomes were very positive in terms of reducing PTSD symptoms, and it did so without any noticeable side effects. So there are intranasal forms of ketamine, and there are many studies underway trying to, you know, investigate the utility as well as the efficacy of intranasal ketamine for post-traumatic stress disorder. Now, another area of investigation is neuromodulation as a therapy for post-traumatic stress disorder. And more specifically, repetitive transcranial magnetic stimulation. And this is generating a magnetic field to treat post-traumatic stress disorder, more specifically stimulating the ventromedial and dorsolateral prefrontal cortex. And these are areas of the brain that are important in terms of extinction learning. And so, that is sort of the mechanistic explanation for why repetitive transcranial magnetic stimulation may be effective. Now, another agent that, has also received a great deal of attention and is under investigation is the use of methylphenidate, which is, an FDA-approved treatment for ADHD. But, investigating methylphenidate for post-traumatic stress disorder in the context of traumatic brain injury, so mild concussive brain injury, which is a very common comorbidity in PTSD, and it's often underdiagnosed. And there has been one trial showing a good effect, both in terms of PTSD, but also functional improvement. Now, an area that has, I think, received a lot of attention, both by the media, but also by the scientific community, is using medication as an augmentation to facilitate psychotherapeutic intervention, and using psychedelics in this regard. So you may be aware of a trial that was published that received a good deal of attention. And this was a trial, a randomized controlled trial of MDMA-assisted psychotherapy in patients who had severe post-traumatic stress disorder and were also treatment resistant. So they had been treated with previous trials of both medications as well as psychotherapies and had not responded to those treatments. Now, why would a psychedelic be effective in the management of post-traumatic stress disorder? Well, what MDMA does is that it does enhance activity in a part of the brain that plays a very key role in fear extinction, and that's the ventromedial prefrontal cortex. And prior to this randomized control trial that received much attention, there were a few open label trials of MDMA that were conducted by MAPS in the US. And they're an organization that actually have developed and provide training on the facilitated psychotherapy that is used in conjunction with MDMA. And because of the signal for improvement that emerged in those open label trials, the Food and Drug Administration announced MDMA as a breakthrough treatment for PTSD. And this was while the randomized control trial was underway. So just to say a bit more about this RCT, this was a trial that was conducted in 90 participants who were either given the MDMA-assisted psychotherapy, or they were given placebo-assisted psychotherapy. So they had psychotherapy and they were given a placebo pill. This is a very intensive treatment approach. It entailed pre-facilitation sessions, so preparatory sessions, and those were unmedicated sessions. There were 90-minute preparatory sessions. There were 3 of them. And this was then followed by the intervention. And the intervention is in fact an 8-hour session administered 3 times. And before the session, the patient then takes a pill of MDMA. So in this trial, they either took the MDMA or placebo and had these facilitated therapy sessions. The sessions are also facilitated by 2 therapists, and they're done under very specific conditions. And so this was then followed by 3 reintegration sessions where patients did not take any treatment. And the results of that trial are hugely encouraging. So I showed you the effect size for psychotherapy trials overall for post-traumatic stress disorder. For this particular trial, the effect size was large. It was 0.91. And patients who were on the MDMA-assisted psychotherapy had significant improvements, both in terms of their PTSD symptoms, but also in terms of functional improvements. Now, another low-intensity intervention that is also receiving a lot of attention is exercise. Exercise as an augmentation for PTSD, but exercise, has been investigated as an augmentation for anxiety disorders as well as mood disorders. So it is, I think, encouraging that the World Health Organization has also recommended exercise, and more specifically 75 to 150 minutes of more vigorous physical activity during the week, or 300 up to 300 minutes of moderate intensity activity during the week to reduce symptoms of anxiety. These are, I think, some of the interventions that require more investigation. So I'm going to end off just with some last thoughts. And I think that, considering the conceptual problems that, the field has been faced with and continues to be faced with, the challenges that researchers and clinicians have in terms of the early identification of post-traumatic stress disorder, it is really important that we focus our efforts on identifying novel mechanisms, and these need to be novel mechanisms that can actually be translational in their effects, because this is the only way that we're going to be able to overcome some of the major barriers that we face in terms of our current evidence-based treatment. So I think that needs to be one of the top priorities, if not the top priority, in the field of traumatic stress. Thank you very much for your attention, and I apologize again for my slides.
Kath, is that my cue?
Hi, Ashraf. Yes, it is.
Okay. I thought you were going to take over afterwards. Sorry. Good afternoon, colleagues. I'm Ashraf Kaji. I'm the co-director of the Center on the Stellenbosch side. I'd like to thank Professor Seedat very, very much indeed for this comprehensive presentation on post-traumatic stress. These are very sobering data that you've shared with us on trauma and post-traumatic stress. We live in a country where traumatic events are unacceptably high, have very high levels. But you've also given us some hope that some of the treatments can have good effects and that people can actually improve as a consequence of psychotherapy and other interventions. It's my job to field the questions, and I'm going to the chat. And there's a question from Professor Ward, Kathy Ward. Thanks, Soraya, that was lovely. Could you perhaps say a little more about barriers in the health system to delivering evidence-based treatments, if you can? I'm curious to hear what those barriers are. Over to you, Soraya.
So there are many barriers to accessing treatment for post-traumatic stress disorder. One of the major barriers is stigma, especially stigma in the context of interpersonal violence, and both women and men accessing treatment for post-traumatic stress disorder. I think there are also barriers in terms of the availability of treatments and effective treatments, especially psychotherapeutic treatments. And so I did not have an opportunity to share some data because of the mismatch in my slide presentation around task sharing and task sharing approaches in the context of post-traumatic stress disorder. So there is far less evidence relative to task sharing approaches
in depression, especially kind of depression on the African continent and other low and middle income countries, and in relation to anxiety disorders, so task sharing psychotherapeutic approaches for those categories of conditions. But in post-traumatic stress disorder, there have been studies of task shifting. I have been involved and currently involved in adopting task sharing approaches to deliver quite complex psychological interventions, such as prolonged exposure therapy and cognitive behavior therapy for insomnia in relation to PTSD in adolescent samples. And so I think, the availability of psychotherapeutic interventions is a major limitation to accessing treatments, and we need to ensure that we can test interventions using task sharing models, but beyond testing them, if they're found to be effective, we also need to find ways to ensure that they are implementable and they're scalable. I think that is one of the kind of major bottlenecks as well. There are a number of other barriers. I think that underdiagnosis is a problem. So most patients with post-traumatic stress disorder will not present to mental health care settings. They will present to other healthcare settings. And they often present with somatization. So especially in the context of sexual assault, sexual violence. And so it's, under detection. And I think that, actively probing for trauma exposure. So making sure that we are all, I think, trauma informed. We need to have a trauma-informed approach to care, medical care. I think that is what is lacking, and that also hinders access to treatment. So it hinders patients being moved along the pathway of care, because they may present to primary care settings, but trauma is often undetected and the effects of trauma undetected.
Thank you, Prof Seedat. The next question is from Candice Clark, who's investigating the effects of yoga on post-traumatic stress. And there's only research in the USA and Europe. Is there anything related to this in Africa, and preferably sub-Saharan Africa? Any thoughts on yoga?
Not that I'm aware of. I have not been involved in any research on yoga. I think there is more evidence on mindfulness-based interventions for post-traumatic stress, especially as a selective prevention strategy, but also as a more kind of universal prevention strategy, mindfulness-based interventions. I did not get an opportunity to speak about COVID and conceptualization of trauma and post-traumatic stress during COVID. But many of the interventions, preventive interventions, including mobile app interventions, include, these other types of relaxation strategies, mindfulness, yoga, other, exercise-based strategies, often with a kind of a coach, but also self-administered interventions.
Thank you. I think your response is also relevant to the next question, which I'll read, and perhaps you may or may not want to add to it. Many thanks, Soraya. That was wonderful. This is from Ruth Levin Forster, who says, I'm curious as to the perspective on embodied therapeutic treatments that work the prefrontal amygdala loop and address the trauma survivor reintegrating back into their body. For example, mindfulness, which you mentioned, and compassion-based therapies?
So these interventions have been shown through brain imaging studies, more specifically functional imaging studies, to correlate with PTSD symptom response. So neural circuitry changes in the limbic cortex, in the prefrontal cortex, been shown to correlate with beneficial improvement in symptoms, as well as quality of life and functional improvements. So we do know that these interventions work. Much of that data comes from trauma-focused interventions. And I think this is a question that still plagues those of us who are conducting research in the trauma field. And, the relative benefits of trauma-focused versus non-trauma-focused interventions, because we know that non-trauma-focused interventions can also be effective, like supportive counseling. So the task shifting study that I mentioned, that I was an investigator on, comparing prolonged exposure with supportive counseling in adolescents, showed that supportive counseling did have beneficial effects. The effects were not as large as prolonged exposure therapy, but there were certainly effects. And so we should not discount non-trauma focused therapies. Supportive counseling is much easier to teach lay workers to deliver, and it is also much less intensive to deliver.
Okay, thank you very much for that. We have a question from Narisha Pillay, who asks, in terms of early interventions for PTSD, what does the research show regarding perinatal mental health interventions, particularly in the first 1,000 days? Are there long-term follow-up studies on these cohorts?
Not that I'm aware of in terms of post-traumatic stress. I mean, there's studies in depression, postnatal depression. I think, post-traumatic stress is an under-researched area. It's been primarily investigated or, researched in the context of intergenerational effects of trauma. So the kind of transmission of the biological and psychosocial effects of trauma from mother to infants. So I am not aware of kind of specific interventions that have been developed in the early postnatal period for post-traumatic stress. I think in the field of depression, there's good evidence that early interventions can very positively impact on long-term maternal as well as infant neurobehavioral and emotional outcomes.
Thank you, Soraya. From Claire Maria, we have a question. Can you maybe explain why the prescription of benzodiazepam is sometimes contraindicated for PTSD?
So benzodiazepines have consistently been shown to be ineffective. And there haven't been many randomized control trials, but those randomized control trials that have been done show that if you administer benzodiazepines, so maybe I should just take a step back and say most of the trials of early interventions of medication treatments, as well as psychosocial interventions, have been delivered within the first few weeks post-trauma exposure. So the trials of benzodiazepines have delivered this medication, or they've administered this medication to adults, within a few hours to a few days of the trauma, and then followed them up to 6 months. And have shown that there is no improvement in PTSD symptoms.
And there have been 2 randomized controlled trials that in fact have shown that benzodiazepines are potentially harmful because when you administer them early on and you monitor the outcome over 3 to 6 months, PTSD symptoms can in fact worsen. And so just in terms of the, mechanistic effects, it doesn't appear as though kind of benzodiazepines have any direct effect on kind of the limbic prefrontal cortical circuitry and on kind of fear extinction in post-traumatic stress disorder.
Thank you. We have a question from Bonga Chaliza. A great presentation, Soraya. I was wondering about the phenomenology of PTSD in people with other mental illnesses, for example, in people with schizophrenia. Are symptoms perhaps different, less pronounced, and therefore sometimes missed?
Yes, so this is not an area of expertise, but I have done some work in the context of PTSD and psychosis and PTSD and, the overlap with schizophrenia. And there is definitely an overlap in symptomatology, but this is where I think, the question of underdetection also comes to the fore in patients with serious mental illness, because we often forget to inquire about trauma exposure and then assess as a follow-up for post-traumatic stress disorder. So post-traumatic stress disorder is common in patients with schizophrenia and other psychotic disorders. That has been consistently shown. And when one looks at the symptoms, there are overlapping symptoms. It, I think, becomes particularly challenging in patients with schizophrenia to differentiate some of the intrusive phenomena of post-traumatic stress disorder from perceptual disturbances that patients with schizophrenia may experience. The hallucinations, illusions, other perceptual disturbances. There are assessment tools that one can administer to try and distinguish post-traumatic stress disorder from psychotic phenomena in these patients. I think the timing of assessment is also important. And so in order to make a diagnosis, one actually needs to have repeated assessment, because if you're assessing patients during, an acute episode of psychosis, may be very difficult to establish whether post-traumatic stress disorder is present. And so, this is an area that I think we tend to we tend not to focus on. And we know that antipsychotics, for example, the second generation antipsychotics that we use to treat patients with schizophrenia are also effective treatments, especially as augmentation treatments for patients with PTSD. Patients with PTSD can also have psychotic features. And so, that sort of complicates the picture even more. So you can have a patient who doesn't have schizophrenia or other primary psychotic disorder, but may have psychotic symptoms, paranoia, even sort of persecutory ideation, and even have perceptual disturbances like hallucinations.
Thank you. We still have a few minutes, so I hope, sorry, you don't mind if we carry on with the questions.
Yes, not a problem at all.
Okay.
And if there are no questions, maybe I could also just briefly discuss what I was intending to, and that is sort of COVID and PTSD, but we can go with the questions if you prefer.
Whatever works for you, Soraya. There are questions, but if you want to share with us some of your COVID-related work, that would be fine, and then we can return to the questions.
So not specifically my COVID work, although I'm really involved in kind of multinational studies, one in particular that in addition to post-traumatic stress disorder also examined other sort of common mental health problems, and that data is still being analyzed. But what we do see are very high rates of post-traumatic stress symptoms, so not disorder, because this was an online survey. And I think this is where there is a lot of sort of contagion and contamination during sort of this pandemic, is post-traumatic stress symptoms often conflated with the disorder. So, I think we need to, when we examine the literature on post-traumatic stress during COVID, we need to distinguish between symptoms and disorder. And in most studies that have been done during this pandemic, but also during previous pandemics such as MERS and Ebola, and the previous SARS pandemic, and so on, it was post-traumatic stress symptoms that were examined, because these were studies that were primarily kind of surveys and use self-report measures. And if you look across all of the studies that have been done during COVID and then the previous pandemics, only about 5 to 10% of those studies included clinician assessments, so clinician diagnostic measures. But one of the challenges with, assessing for post-traumatic stress during this pandemic is the issue of conceptual and criterion creep. And that is why I wanted to really highlight COVID as an example of where, this field is sort of so, I think, plagued. Because how do you assess for criterion A events in the context of COVID? The criterion A events would be the traumatic events, and there are divided opinions on whether COVID-19 in fact meets the definition. So if we're all exposed to this pandemic on such a mass scale, is the pandemic itself a sufficient index event for post-traumatic stress disorder? And so the individuals who say that it is not, and they say that we should actually be thinking of a different conceptualization of the effects of stress as a result of COVID-19. We may want to think about a syndrome known as COVID stress syndrome. And there have been very specific criteria that have been put forward for this COVID stress syndrome. So I think that's the question. It's the issue of sort of conceptual and criterion creep. What are the events, traumatic events, that would meet the definition for post-traumatic stress disorder? Because according to the DSM-5 and to some extent the ICD-11, it needs to be, some sort of kind of a life-threatening, serious event that you either directly experience or you witness. So I think that's sort of the first major conceptual issue. The other is sort of how you anchor your assessment of post-traumatic stress to those events, because many of the studies on COVID really just ask respondents whether they are experiencing post-traumatic stress on a scale like the post-traumatic stress disorder checklist or some other scale, but they don't anchor the respondents' experience of those symptoms to any index event. And so you don't actually know what is being measured. And it's also kind of the temporality of assessment, because this is an ongoing pandemic. COVID-19 and, other pandemics, if we want to think about them as traumatic events, they are in marked contrast to what we think about of as post-traumatic. It's post-traumatic because the trauma has already occurred. Yet during this pandemic, stress reactions, and events are not necessarily post. So, the question is, what is one actually measuring? Is what we're measuring more attuned to an adjustment disorder, like a pandemic-related adjustment disorder? And, some would argue that this is more fitting than post-traumatic stress disorder.
Thank you, Professor. You've brought into focus some very complicated issues And I guess there's no one answer to the questions that you've raised, but it's important for us to continue thinking about it. There's a question from John Parker. Thank you, Prof. The ICD-11 criteria for complex PTSD seem to share a number of features with borderline personality disorder criteria. Is there some guidance on differentiation, or is this simply a recognition that there is a very high level of co-occurrence of these disorders?
So I think that the ICD-11 has approached this from kind of the latter perspective, that there is a very high rate of co-occurrence, and that individuals who meet criteria for borderline personality disorder may in fact have complex PTSD. So, you know, once again, it is around the issue of criterion creep. But, you know, complex PTSD is not an exclusionary diagnosis. So, you know, I think that one needs to maybe err on the side of making the diagnosis of complex PTSD and borderline personality disorder, especially if the other core symptoms of PTSD, I think that is probably for me the differentiation. If you have a patient with borderline personality disorder who meets the ICD-11 or DSM-5 criteria for post-traumatic stress disorder, if you've diagnosed borderline personality disorder, I mean, you need to consider co-occurring complex PTSD.
Okay, thanks. That's a very helpful response to that question. There's a question from Osamuddin Ogimuder, who asks, are you aware of some evidence, i.e. anecdotal, scientific, or empirical, investigating the linkage or association of adverse religious experiences, religious trauma and spiritual abuse to or with complex post-traumatic stress disorders? It's a question about adverse religious experiences.
So I am aware of literature in the kind of torture, the torture research. So torture and sort of refugee populations where, you know, spiritually related kind of traumas in addition to kind of physical traumas, so torture-related traumas, you know, have been described and have been shown to not only be associated with post-traumatic stress symptoms, but a wide range of other psychopathology, but not in the context of kind of other mainstream kind of civilian types of trauma and civilian trauma populations. I mean, that said, religion has been shown, or spirituality in particular, has been shown to be, you know, to have positive, to have kind of positive effects, protective effects in individuals who are trauma exposed and have post-traumatic stress symptoms. So that has been consistently shown as a protective factor, spirituality. And many kind of resilience bolstering interventions actually include spirituality more than sort of kind of religious components in an intervention, especially kind of at an individual level, but even at an organizational level, you know, and that I think has really come to the fore during this pandemic.
Thank you, Soraya. One last question I think we have time for. With the recent apologies from the American Psychological Association about systemic racism, might there have been underdiagnosis of PTSD in low and middle income countries due to the perspective on what or how PTSD presents in different communities? And this is a question from Dominique Eugene.
Yes, so interesting. I was invited to write an editorial for the Journal of Traumatic Stress, an issue that specifically focused on kind of intersectional traumas, racism, other forms of discrimination, and the association with post-traumatic stress disorder. So it's a collection of papers, and really kind of got me thinking about how COVID-19 has impacted on the relationship between racism, discrimination, stresses, and PTSD. So Dominique is a visiting Fogarty Fellow in my group. She's just arrived. And so I imagine that she will be speaking sort of or thinking about this from a US perspective. So in South Africa, there is a literature on the association between racism and post-traumatic stress disorder. I haven't made any kind of substantial contribution by any means to that literature, but we do know that discrimination stresses have been identified as traumatic events for PTSD. And so here again, there is a kind of divided camp because it is, you know, about how narrowly or how broadly you define trauma for post-traumatic stress disorder. But there have been many studies that have accepted that discrimination or racism is an index trauma for PTSD, and then have examined post-traumatic stress disorder. And there is a good deal of literature on the biological effects of racism, the adverse biological effects of racism. So how discrimination stresses can actually kind of get underneath the skin, how they impact on biological aging, on you know, on endocrine and sympathetic responses to stress. And so, you know, these are kind of measurable stresses. And I would, you know, argue that it is more about the impact on the person than about the event itself. I think, unfortunately, we have been constrained by the DSM-5 and ICD-11 in how we kind of conceptualize trauma, and maybe we need to be more broad-based in our approach.
We've come to the end of our time together, and for the questions that haven't been answered, we can send responses by email later. Soraya, I'd like to thank you very, very much indeed for sharing with us your knowledge about post-traumatic stress. This was a hugely comprehensive presentation. You've demonstrated your expertise, and I want to thank you for helping us remember the legacy of our colleague and friend Alan Flisher with your very comprehensive and expert lecture. I have noticed a couple of Alan's family members in the audience. I see Khalila's name and Meronisa. I do want to acknowledge you and welcome you belatedly to this event. Professor Seedat, thank you very, very much indeed for sharing with us your expertise. And colleagues and friends in the audience, thank you very much for your attendance. We are very grateful to you for supporting the Alan Flisher Center for Public Mental Health.
Thank you very much for inviting me.
Thank you. And with that, we can conclude. Thank you so much. Bye-bye.